Greetings to you all from Boston. My name is Katherine Semrau, and I am the director of the Better Birth program at Ariadne Labs. I hope you and your family are staying safe and healthy during this pandemic. Thank you to Rima and the organizers of this technical consultation, turning it virtual. I look forward to learning from you all over the coming weeks. Over the years, there has been a call to action to improve uptake and implementation of respectful maternity care through improving training and education for maternal health care workers. And I have been asked to focus on Construct 4.1, a proposed new indicator focused on national pre-service curriculum for maternal health workers and the inclusion of respectful maternity care in that curriculum. In the EPMM Phase 2 process, the formulation of an indicator for this construct is focused as follows. Presence of a component that specifically addresses the universal rights of childbearing women, the RMC Charter, in the National Pre-Service Education Curriculum for all midwifery service providers. In 2018, when the World Health Organization recommended RMC and released the guidelines, there was a call to include professional societies and training institutions for maternal healthcare providers to be involved in policy and curricula development and modification. However, there are no current indicators that are focused on this pre-service curriculum evaluation or monitoring. In order to think about this construct of pre-service curriculum, there are some key words which require focus. To be clear, this construct and indicator would be measured at the national level. It would require identification and assessment of pre-service curricula, which is expected to be distinct from in-service training or postgraduate training. We must clarify what component or components of training means and what is sufficient to be considered inclusive and meeting the spirit of the construct. Finally, we must determine who is to be included as a maternal health care worker. Should this be midwives only or include nurses, obstetrician gynecologists, or others? There is not a current indicator or structure that is monitoring pre-service education with respect to RMC inclusion. Operationalization of the RMC Charter framework and creation of definitional standards for RMC is ongoing and in early stages of development. While examples of programs and approaches to RMC training are proliferating, there has not been synthesis of provider-level standards for RMC, and thus curriculum and professional society standards have taken various approaches to defining RMC in their own work. In a forthcoming systematic review, which I have been working on with Rima Jolove and Jigyasa Sharma, it is clear that operational definitions around RMC have been limited and disjointed. Further, these operational definitions and approaches provide the basis by which professional societies engage in standard setting and establish criteria for pre-service training and the associated institutions to develop curricula. Building on these operational definitions, we have been reviewing professional practice standards set by ICM, ICN, and FIGO, which act as the guidelines for the pre-service training for frontline healthcare professionals, including those in maternity care. With the ICM, ICN, and FIGO guidelines, we have a variety of countries with different resources and years of professional society establishment. In the reviews to date, it is clear there is wide variation in the operationalized definitions, languages, and choices of RMC rights included or excluded in those professional standards. I believe this construct and associated indicator around pre-service engagement and curriculum development are important aspects to advancing RMC implementation, normalization, and institutionalization. In a brief PubMed search in preparation for this presentation, I found only 346 peer-reviewed articles address pre-service training. Only 14 of those specifically addressed pre-service childbirth training, and only 5 of those included respectful maternal or maternity care. The construct makes sense scientifically and logically. Globally, if we want RMC to be a universal right and truth, we have to define and clarify where it should be taught and how it is integrated into national standards of education of the health workforce. However, as a current metric does not exist, we need to consider field testing to this proposed indicator. Feasibility of measuring this construct, however, is more challenging. Since there is not a current singular metric around respectful maternity care and healthcare workforce education, this would require an initial lift for data collection. There are likely sources of high quality data, including information from professional societies, associations of medical education groups, and ministries of health and education. Another key group to consider reaching out to would be the World Health Organization's Global Health Workforce Network. As a new construct, I believe this would be well harmonized with the indicators under EPMM and more globally the maternal health efforts. Many indicators currently focus on policy or service delivery of care. This indicator fills a gap around pre-service education and does not duplicate information that is gathered elsewhere. With respect to relevance, understanding pre-service education and awareness of RMC as part of the core curriculum for maternal health providers would directly support the EPMM strategies for reducing preventable maternal mortality. While there is not current evidence that suggests RMC curricula alone reduces mortality, it certainly has an impact on provider care and patient experience. Finally, a simple, measurable indicator around pre-service curriculum is easily interpretable at the highest levels and actionable. With this information, countries could compare curriculum at the global level and over time. Information on which RMC constructs and rights are included could be beneficial to lead curriculum adaptation and change. The information gathered could advance policy and programming across many stakeholders. Given that pre-service education and training is often the engagement of stakeholders in education, health, professional societies, and businesses, this indicator could provide direct insight into advancing RMC implementation, normalization, and institutionalization. I look forward to the continued discussions around Construct 4.1 in defining and assessing an indicator verifying that the national pre-service education curriculum for maternal health workers includes standards of respectful maternity care. Thank you.